Hey everybody, this session is going to talk about inflammation and specifically focus on Gerd and PUD. Specific objectives are going to be talking about causes, signs, symptoms of PUD and Gerd. We want to talk about the treatment goals for both. Talk about drugs used to treat PUD and Gerd. We're going to talk a little bit about Helicobacter pylori and how do we treat that, because that's really important. As always, we're going to talk about the nurse's role in pharmacological management, always focusing on those prototype drugs and how we're going to use those and what we need to teach, and then ultimately the nursing process and patient education for both PUD and GUD, or GERD and PUD. Sorry about that. So a little overview with the stomach. There's two muscular rings or sphincters that kind of control everything that's going on. The first one's going to be the esophageal or cardiac sphincter, and this is going to keep food from moving from the stomach back up into the esophagus. The other one's the pyloric sphincter, and this is going to regulate flow of substances that leave the stomach. A little bit more about the stomach. The stomach has chief cells, and these secrete enzymes, most specifically pepsinogen. You have parietal cells that secrete hydrochloric acid to break down food. This is also going to activate pepsinogen and can kill microbes. The stomach also has intrinsic factor, which helps absorption of vitamin B12. We're not going to get too deep in that. Just know that that's what it does. The stomach also has like a mucus layer and bicarbonate ions, and this is going to help protect the stomach mucosa from the acid that's in the stomach. All of these things are to do a couple of things. It's going to provide balance, it's going to help digest food, and help protect the stomach. So when we're thinking about peptic ulcer disease, we need to talk about a few risk factors, and there could be several risk factors. Clients that have a history of peptic ulcer disease, smoking, caffeine use, many medications like corticosteroids, NSAIDs, excessive stress, and of course H. pylori infections. For Helicobacter pylori or H. pylori, primary cause of peptic ulcers. This usually is caused by gram-negative bacterium. Other causes that can contribute to ulcers and eventually inflammation are excessive gastric acid, decreased or adequate mucous membranes that are in the stomach, that NSAID use. This is most common in clients that do not have H. pylori. Treatment goals for peptic ulcer are going to focus on eliminating H. pylori if that's the cause. We want to promote ulcer healing and prevent recurrence of any symptoms. There's a few different types of drug used in treatments, and we're going to talk about those a little bit more in depth, but we're going to focus on the starred ones. Treatment specific for H. pylori is that we want to completely eradicate this bacteria, and I think we're going to talk about this maybe a little bit more when we get to infection, because we're going to focus on bacterial treatments. There's a very high reoccurrence with peptic ulcer, especially if it's related to H. pylori and it's not eradicated. So just a general rule of thumb when we're thinking bacterial infections, you want clients to be on antibiotics, take their whole treatment, otherwise there could be a high reoccurrence. And then the infection can remain active for life if it's not fully treated. This is all going to help ulcers heal quicker and keep the remission, make sure it lasts longer. So when we're thinking about peptic ulcer disease, you can have different types of ulcers, and those are duodenal or gastric. For duodenal, just know that they're more common than gastric, and they occur commonly in clients ages 30 to 50. Usually the symptoms are going to be a gnawing or burning upper abdominal pain, and this can occur within 1 to 3 hours after meals. The pain's also going to be worse when a client has an empty stomach. Some other symptoms, clients may experience pain at night or even nausea and vomiting. Bleeding can occur, and what you might see with that is bright red blood in their emesis or black tarry stools. So when you're thinking about blood and what you see and where it comes from, if they're vomiting blood, usually that's like upper in the GI tract, it's new, it's recent, that should be a key. And if it's black tarry stools that they're seeing, then it's either something that's resolving or something lower in the GI tract. Gastric ulcers are less common, but they can be more common in elderly population, usually about 60 years old or greater. They're also going to manifest with pain, but that pain is going to be relieved after ingesting food, or it actually could continue after a meal. Not to make it confusing, but those are some of the things we need to think about. It may be present with anorexia, weight loss, and vomiting. It's most commonly associated with cancers. So GERD or reflux disease is caused by the loosening of that esophageal sphincter, commonly associated with obesity. The acid is going to move up and increase, and that can cause an intense burning, or what's commonly known as heartburn. This can lead to esophageal ulcers, esophagitis or inflammation of the esophagus, or even strictures where things start to kind of harden up and close up, and this is going to make the esophagus not work as good as it could. Lifestyles can definitely change or improve GERD. Treatment of reflux is treated similar to peptic ulcer disease. So basically our primary goal is to reduce gastric acid secretion and treat the clients. Common classes of medications to treat GERD or PUD are going to be your proton pump inhibitors. We're going to talk about those. H2 receptor agonists, or they're sometimes called H2 blockers, and we're going to talk specifically about antacids. Antibiotics bring on for H. pylori, and there are other miscellaneous drugs that may be used. So the first med that we want to talk about is Prilosec, or omeprazole. This is a proton pump inhibitor. It can come in prescription or over-the-counter form. Basically what this med is going to do is it's going to reduce acid in the stomach. It can be used briefly or for a little bit longer, typically about 4 to 8 weeks, and it's very effective for a condition called Zollinger-Ellison syndrome. Right now, if I'm not mistaken, it's only available in oral form. Administration considerations: you want to make sure you give this medication before breakfast or on an empty stomach, and this can be given with antacids. Just make sure you don't crush any tablets or capsules or cut them in any way, shape, or form. When we're looking at adverse effects, common symptoms that you may see are headache, nausea, vomiting, diarrhea, rash, or abdominal pain. Rarely it can cause blood disorders that you're going to see with manifestations of a particular blood disorder. Prolonged treatment may cause low magnesium levels, so you want to look at that lab. As always, don't use contraindications. Don't use if they have a hypersensitivity to the drug, and you want to be mindful when this is used with CNS depressants, Coumadin or alcohol use. When we're looking at labs, you want to look at those liver labs, and again, look back at that magnesium, especially if a client's been on it for a little while. If those magnesiums drop, then a client can have many potential consequences with that. When we're looking at herb or food interactions, tell your clients not to take any ginkgo biloba or St. John's wort, and right now there's no overdose considerations. When we're looking at another drug, Zantac, this is your H2 blockers, very important as well. You're going to see this a lot in your practice. This is actually going to block the H2 receptors, and this is going to eventually lead to decreased acid production. This is usually given IM or IV, especially for stress-induced bleeding ulcers. Want to make sure you give this medication after meals. Adverse signs and symptoms, things you want to think about, very common is headache, but this may also, on rare occasions, reduce white blood cells, red blood cells, and platelets, so you want to make sure you get frequent labs. Low red blood cells could cause problems with perfusion oxygenation manifestations, white blood cells, viral or bacterial infections, depending on which way that goes, and then frequent, when we're looking at the platelets, we always want to look at platelets. So if it's going to reduce the platelets, then we know our client's at risk for bleeding and risk for injury. Again, don't give this medication if they have a hypersensitivity to it. You want to make sure that you do not give antacids within 1 hour of the H2 blockers, because this is going to decrease their effectiveness. And again, have your clients quit smoking or reduce if they can. With labs, you want to watch your renal panel, CBC, look at the liver panel. We want to make sure everything's working. Also take a look at their urine, because this medication could cause false positives for protein in the urine. Herbal considerations or food considerations, this medication could cause B12 deficiencies and may also reduce iron absorption. No current overdose considerations. When we're looking at aluminum hydroxide, this is one of the antacids, one very common, again, you're going to see in your practice. This is used to neutralize stomach acid by increasing the pH. Remember, making that balance. Know that they're not going to decrease acid. They just kind of neutralize it. You want to make sure you give these 2 hours before or after other medications. One adverse reaction that may happen is constipation, and may also decrease phosphate levels. So be mindful if you have clients that are malnourished and liver disease or renal failure, their phosphate levels can already be a challenge to manage depending on their condition. So always take a look at those labs related to that. Do not use this medication if a client has a bowel obstruction. If they already have a bowel obstruction and this medication is going to cause constipation, then it's going to make the bowel obstruction worse, which means nothing's moving past that obstruction, and this can be a life-threatening emergency. This medication, you don't want to take it at the same time with some other medications. Your labs, you want to make sure you look at the urine pH and, of course, phosphate levels for our renal and liver patients. This medication can decrease the absorption of iron, and no overdose considerations. So with regard to nursing process and client education, we're going to do something just a little bit. I've given you the prototype meds and kind of run down some really specific items. When it comes to the nursing process and what you're going to teach, I want you to take a look back at your textbook, and there's a chart in there that's going to run down, assess, diagnose, plan, implement, and evaluate, and also talk about what you should teach. It would be helpful if you kind of put that into a table or a chart or a bullet form that makes good sense to you. And as a helpful hint, I want you to kind of pull out the things, either nursing process or education-wise, that are different from other meds that we've discussed with other concepts and exemplars. And if you want to, go ahead and post those in the Prep for Exam 2 forum. Post 1 or 2 things and get our discussion started. All right, so you have any questions about this presentation, go ahead and post those in the Prep for Exam 2 forum located in your Blackboard course.